Welcome to the third episode of IMPACT Medicom's podcast series on immunotherapy in head and neck squamous cell carcinomas. In this episode, hosted by IMPACT Medicom's Sarah Doucette, we welcome Dr. Martin Smoragiewicz, Medical Oncologist at the Odette Cancer Centre in Toronto, Ontario. This episode discusses the medical oncologist's role in managing patients with head and neck squamous cell carcinomas and how immunotherapies fit into their practice. Hope you enjoy it.
Hello, listeners. To finish off our series on immunotherapy in head and neck squamous cell carcinomas, our guest, Dr. Martin Smoragiewicz, will be sharing a medical oncologist perspective on the topic. So welcome, Martin.
Hi, thanks very much for having me. Pleasure to be here.
So can you start us off by telling us a bit about your interests as a medical oncologist?
Yeah, so I'm a medical oncologist practicing here at the Odette Cancer Centre at the Sunnybrook Health Sciences Centre. And my practice is about half focused on genitourinary cancers and the other half in head and neck cancers. And my interests really are in clinical trials and really bringing, therapeutic options to patients in clinic, and with a specific interest really in immunotherapy-based therapeutics.
And how has your approach in managing head and neck cancers evolved since immunotherapies have become available?
Well, immunotherapy really has changed the landscape treatment options in many different cancers, and head and neck is really no exception. When I started practice and, started treating head and neck patients, we had just had approval of nivolumab in the second-line setting for patients with head and neck cancer that had progressed after previous platinum-based chemotherapy or relapsed within 6 months of chemoradiation. And, the results of Checkmate 141 were, exciting. They had shown an overall survival benefit compared to some, the alternative chemotherapy agents used in that trial. And indeed, nivolumab can work very well in some patients. There's probably about a 15% response rate. And I certainly have patients in my practice that have responded very favorably for, prolonged periods of time. But in most patients, it's actually not effective. And the other problem is that, there's a significant proportion of patients who are just too unwell to receive nivolumab after they've progressed on first-line chemotherapy. And so for this reason, it was very exciting to see the Keynote 48 results a few years ago now, which the trial evaluated pembrolizumab with or without chemotherapy in the first-line setting for patients with head and neck squamous cell carcinomas. And this showed an overall survival benefit compared to the comparator arm, which was the chemotherapy plus cetuximab. So this led to, the approval of pembrolizumab plus chemo in the first-line setting, irrespective of the CPS PD-L1 status, but also the approval of pembrolizumab as monotherapy in patients with CPS PD-L1 greater than 1. So this was really an important development for our patients to have access to the immunotherapy much earlier in their disease course, and probably overall, increased access to these patients. After about a year or so of using pembrolizumab in the first-line setting, I find it very nice to see how sometimes you can achieve very deep and durable responses to the pembrolizumab that was given either with or without chemotherapy. But, there's certainly a significant proportion of patients that just don't respond, and there's a lot more work to be done for these patients.
So managing these patients, it's really important to have a multidisciplinary approach, and that's important for a number of tumor sites. Can you discuss how it's important for the treatment of head and neck squamous cell carcinoma?
Yeah, absolutely. I think, it's one of the disciplines that requires really a very good functioning multidisciplinary team to deliver, the highest care possible. And really, as a medical oncologist, we're involved often quite early in the patient's journey, and we work very closely with the surgeons and the radiation oncologists. Our involvement often starts at the initial presentation of the patient. Often these patients present with locally advanced disease where they require chemotherapy and radiation, or potentially post-operative chemotherapy and radiation. But unfortunately, of course, a fair amount of these patients will relapse, and at the time of relapse, we work very closely with our surgeons to figure out whether we need to get additional biopsies, to confirm a relapse or for biomarkers, and also with our radiation oncology colleagues for trying to determine whether additional radiation may be required for symptom control and and ultimately also to help with some of the complications that arise from some of the previous treatments. So, really important to have close communication with our surgeons, our radiation oncologists, and also our pathologists.
And so I was going to ask, what do you need from those other team members and what do they need from you in order to work most effectively?
Certainly in the definitive space, the radiation oncologists really want to know if their patient is going to be a candidate for chemotherapy. So it often involves, medical assessment of their fitness and looking at some of their comorbidities, as these patients tend to have a fair amount of comorbidities. In the relapse setting, our surgeons often ask us whether, they need to repeat a biopsy, for example, to determine, an additional biomarker, in this case, often CPS PD-L1 score. So there's lots of questions that certainly go two ways.
Talking a little bit more about the PD-L1 testing, how does the CPS PD-L1 test results influence your decisions for a treatment choice in head and neck cancer?
Yeah, so this is it's a very important test, the CPS PD-L1 test, for several reasons. In the first instance, really, it's about helping patients to decide on what their therapy options may be once they have suffered a relapse. Specifically, if they are CPS PD-L1 positive, so if it's at least 1 or greater, then they do have the option of receiving pembrolizumab on their own. And particularly if they have a high CPS PD-L1 score, in other words, above 20. A lot of these patients will have had previous chemotherapy and radiation, which often comes with, a quite high symptom burden. And, they may not be interested in receiving additional chemotherapy. So having the option of getting single agent pembrolizumab is valuable to some patients. Although I must admit that my decision to use, chemotherapy or not often actually involves an assessment of their disease burden at the time of relapse, the location of the tumor, the pace of disease. And I often make a recommendation, not necessarily based on the PD-L1 status as much as some of those factors I just mentioned. In fact, looking at my practice, I recently did an audit, and I seem to have a fairly strong preference of using combination treatment in many of my first-line patients.
In terms of PD-L1 testing, if you're going to use it to make treatment decisions, what time do you usually get those results? Is it before or after meeting the patient?
Yeah, so it depends. At the moment, ordering of CPS PD-L1 testing can be done really by any of the members of our head and neck team. And often it happens to be ordered by whoever saw the patient last that, essentially detected the recurrence. And so it could be, the surgeon, could be the radiation oncologist, it could be, myself. And sometimes, in fact, it's ordered, at the time of a multidisciplinary discussion, often at a tumor board where, we have our pathologist there and we can kindly ask them to do the testing. And the turnaround seems to be pretty good. I usually get the result within a couple of weeks, especially if the tissue is in-house.
I would guess you would feel that's a pretty effective process, the way testing is ordered.
I think it helps to have all members of the team aware of the test and of its importance in terms of decision-making. So I think awareness is an important variable here.
And in terms of getting the test done, say, faster, would you see a benefit in testing some patients at an earlier stage of the disease in order for the result to be available upon recurrence?
I think so. I think, certainly for cases where they have a high risk of relapse, it may be worthwhile to do reflexive testing on them so that when the recurrence does occur, there is, you already have the available information to help the patient make, the appropriate decision. So I do think that there certainly is some merit, especially for the high risk cases that come through.
Is that something that you would do in your practice?
Yeah, so currently we work with our pathologist, and there is reflexive testing on essentially any specimen that comes in to the pathology lab where it's clearly marked as metastatic disease. In other words, a setting where it's no longer curable and first-line metastatic treatment is in order. But also in some of the higher risk cases, a high nodal disease or other risk factors that we've discussed with our pathologist.
So what are the biggest advantages and challenges of using immunotherapy for head and neck cancer?
I mean, the obvious benefit is to patients, right? The fact that we now have immunotherapy available in the first and second line setting really gives our patients the option of having access to immunotherapy in any of those lines, and therefore the the potential for some of these durable, responses, especially earlier on in their disease. But, they do not work for many patients, unfortunately. And we certainly still have a lot of work to do in terms of improving upon the current status.
How do you see their use evolving in the future?
There are, at the moment, many ongoing clinical trials looking at immunotherapy in earlier disease states still. So there's a number of trials going on looking at combination immunotherapy with definitive chemotherapy radiation. There's also some trials looking at perioperative immunotherapy. And certainly some of the earlier data suggests that, these trials will be interesting and hopefully practice changing. So certainly a space to look out for, in the coming few years as these trials report out.
And to end off our discussion, are there any anecdotal cases you can share that kind of highlight the importance of the multidisciplinary team when it comes to treating patients with head and neck squamous cell carcinoma with immunotherapies?
At the moment, we have a number of clinical trials that we have available, and really getting patients on trial often is one of the better options for patients. And for a patient population like this with head and neck cancers, they are quite sick and their disease is often, quite aggressive. And, it's very important that you have a sort of quick, efficient communication with your team members to determine, do they need additional scans and biopsies or potentially other interventions with really the objective of trying to get them onto, next line therapies, which, sometimes involve immunotherapies on clinical trials. So we have number of patients where, this sort of multidisciplinary approach has been very effective at sort of streamlining the care and getting them onto the next line of treatment. So really key, this multidisciplinary approach. And I suspect this is going to become even more important as immunotherapy moves potentially into earlier stages with chemoradiation potentially, or even, in the perioperative setting.
Yeah, well, thank you for that. And thanks again, Martin, for joining us on the podcast, and take care.
Okay, thank you so much.